Hi, so I'd like just to take this opportunity to answer a few more questions that we didn't have time for in the presentation yesterday that came up in the chat. So one of the questions is, when is it safe to start running for someone who's acquired an injury? And so I briefly touched on this, but basically there's no great evidence for when it's safe from a neurological perspective to start running. Obviously we have to manage falls, and you can do that with various devices, and we use transfer belts while people are walking or trying to run. But from a neurological perspective, despite all the work that's been done in concussion, there's not much work being done at all with more severe types of brain injury. So we used to have an arbitrary 6-week rule. We've just recently changed as a result of Sarah Aldis's PhD work, which is yet to be published, which is being written up for submission to a journal. And so now our practice has changed to become, we use the concussion guidelines to monitor our patients. So when we start to do more challenging exercises, just monitoring, do they have any exacerbation of those symptoms? And the symptoms from following brain injury, almost entirely map the symptoms for concussion. So do they have more of a headache, blurred vision, fogginess, stuff like that. So we use the concussion, the SCAT-5 checklist to monitor our patients when we get them running. Then the next question related to that was, how do you manage or stop falls? So many of the initial exercises we do that showed videos of, like on the leg sled or the trampette, they're laying down or holding on, so they're not a risk. But when you start to go overground, that's the where the problem starts. So there's one key thing to reduce falls there, and that is that a normal a healthy, able-bodied person is going to run or start to run faster. That strategy for increasing their running speed is to take longer strides. So you push off the ground harder with your calf and you take longer strides. And then the changes that occur to your cadence tend to happen at the higher speeds. So the first strategy to improve your running speed is stride length, and the second strategy at faster speeds is your cadence. So we do the exact opposite. Okay, we train the cadence and get people used to turning their legs over a bit more quickly. And we do that with a very, very short step length. Okay, so I showed some video of that. So very short steps. And basically what that means is, instead of when someone tries to run and they take longer steps, instead of having one foot going from well behind to well in front, and that big translation that has to occur, that takes a long time, and also they could trip. When you're taking short, fast steps, it means your legs are always underneath you. You're much less likely to fall. And that's a key thing, is to separate out your forward speed from your leg speed, and target cadence first and stride length second. The next question was about spasticity, and there was a subsequent question about calf spasticity. The interesting thing about spasticity depends where it is. So there's a paper by Harold Baum in 2018, and we've published a number of papers looking at the relationship between spasticity and mobility. So if we just talk about spasticity and separate that out from, say, hypertonia and dystonia, spasticity in the calf doesn't seem to matter. And Harold Baum's work in children with cerebral palsy found that if you have calf spasticity, you're more likely to be able to run if your GMFC is level 2 than if you don't have calf spasticity. We've also found a similar thing with people with brain injury, and that's an interesting finding. But when you appreciate the biomechanics of how the ankle works, then maybe not so much, because the calf is actually supposed to work like a spring, and a bit of spasticity in the calf enables the calf to act, has that spring-like action even more heightened. So it would become problematic, though, if there was a inversion aspect or a varus aspect to the foot posture. But if it's just purely in the plantar flexion plane, or largely in the plantar flexion plane, that doesn't seem to matter. However, if the spasticity is in the rectus femoris or the knee extensors, that means you're less likely to be able to run. So look up Harold Baum's work. His paper is referenced in the reference list of our first workshop, if you need to find it. And so basically, if you've got spasticity in your rectus femoris, it means that the knee can't bend as very much in swing phase, which means you have a longer, slower leg, and therefore you're less likely to be able to run. Next question from Sarah says she's found that a typical bag of tricks for improving cadence don't work so well with athletes with ataxia and dystonia, particularly with dysdodekakinesia. So any tips? So what we do is what I mentioned before about separating out leg speed from forward speed. So we typically focus on faster movements and trying to make those movements faster, but with a smaller amplitude. So cutting back the step length or the range at which people work. And so from a mathematical perspective, the way I think about it is when people have disorders of motor control, like ataxia and dystonias and things like that, is that bigger movements are associated with bigger error, and that's no good for learning, whereas smaller movements have less variability or less error associated with them. So if we can reduce the amplitude of the movement and increase the speed and have less error associated with those exercises we're doing, that's more conducive to learning. And obviously at some point then we have to progress and bring back the amplitude of the movements that we're exercising through. But we've had most success with containing the amplitude, so smaller movement, smaller error, and then once we develop the control over that, sufficient control to progress, then make those movements larger. Another question was about, do you work on improving core stability at the same time as improving leg strength? So absolutely, and many of the exercises, I think we're doing the same thing at the same time. So I showed a video of a claw exercise, so someone standing there and just doing one running leg cycle. We are monitoring someone's body at the same time as monitoring their leg movements. And so are they able to control and keep their trunk and pelvis still in all three planes while having these increasingly faster and bigger leg movements? And so if you look at elite level sprinting at the Olympics, you'll see people moving their arms and legs incredibly quickly through a large range of motion, and yet their pelvis, trunk and heads are relatively still. So that's really what we need to do. And I'm not sure how well that translates from exercises like, say, on a Pilates reformer where you're laying down, like you might need to start there, but at some point you need to transition to doing these type of exercises, on your feet or on one foot, because you need to be able to control your center of mass and your core over such a small base of support, which is maybe half the size of your foot, if you don't have your heel on the ground. So the running drills that we do, that is definitely challenging the core at the same time, and often we'll be looking at what's happening with the trunk during these various different leg exercises and running drills, and go, they're not happy with the way they're controlling their trunk, so we'll get them to slow down a bit, or go through a smaller amplitude of movement with their limbs in order to control their trunk more. Next question was, do you think training needs to change with age? And commenting on overcome some of the factors related with aging in CP. So look, we train a lot of older people to run, and it's not necessarily to become athletes, but grandparents that want to just be able to engage with their grandchildren, for example. So recently we're teaching a guy how to run who just had a deep brain stimulator put in for his Parkinson's, or some other people with other neurosurgery for brain tumours or strokes, much more commonly. So they've had a reasonably normal running technique in the past, and we're just trying to get back to that. Whereas CP and other developmental conditions are completely different kettle of fish, and so we need to be very careful with their musculoskeletal system, and for those people it takes longer because often they've been compensating with other muscle groups for years, so it is completely weird and difficult for them to learn a new way. But we just go through the same process, so often get them on the leg sled and try to be specific with targeting the calf muscle, for example, And once they do that, then get them to go faster with that exercise or put more load on by increasing the incline, and then on the tram pet, and then overground. So it is a pretty gradual process, but it's probably as much about the skill acquisition as they learn these new exercises as what it is about increasing their strength and power generation. A couple more questions. Is there any aspect of muscle memory and creating new neural pathways with the activity-specific training? Yes, it's although for many of our patients, by the time we get to running, like it could be, you know, a year or a couple of years after their accidents, because they've had not just a brain injury, but broken legs. They might have had a Lazaro frame on their leg. They've had multiple surgeries, so it does take a long time. And it's sort of, in terms of muscle memory, it's sort of weird, but it is like they've actually forgotten how to do it. And so I mentioned before, I think it's about as much as skill acquisition as what it is about actually improving strength and power. Because if you're doing these exercises with a healthy, able-bodied person, then they've already got the skill, whereas vast majority of our patients are trying to relearn the skill at the same time as increasing their strength and power. So all the more reason that our exercise prescription has to be very, very specific. So it's a really challenging thing for many of our patients is they just haven't done it for so long, and it's difficult for them to get back to it. And then there's the other cohort of patients who have never done it. The CP have never had a normal running technique, and yet we're still trying to normalize as best we can their running pattern. And last question was, other than the dynamic or ballistic training, is there anything else we can help to train power for those that have 5 out of 5 strength but lack force generation and function? So probably no. At the end of the day, you get what you train. So if you want to improve power, then you've got to do power exercises, and it might take a while, but it's worth persisting. So it's all about rate of force production. So how quickly can you generate force? So that's what ballistic or power training is. And I'd suggest we persist. And it's a challenge for us as therapists or coaches or trainers, because there's not necessarily a lot of reward for effort in a shorter or medium time frame. Often it takes a long time for people to benefit from the hard work they're putting in. So the challenge is, I think, sometimes that we don't just swap and change what we do. We try to be very specific in identifying what the patient or athlete's main problem is, and then what are the contributing factors. So in terms of power generation, and then coming up with the best exercise for that, and then sticking to that, and not getting bored ourselves, and keeping our patients and athletes engaged and persisting with that, because it just can take a long time. And to help manage that emotional side of the problem of keeping people engaged and persisting, we just use video, and don't do it too often because things take time to change, but every month or two, take a video, and you have to be specific with what you're collecting in the video, and just go, okay, this is where we're at a couple of months ago, this is where you're at now. You can see these changes are starting to take place, and so this is what we need to do to continue to improve. So it's a very powerful tool is the visual feedback you can get from video. And the other thing along those lines is using the slow motion feature, because particularly in running, these movements happen so quickly they can be very difficult to see in real time. Are you achieving what you want? And so that slow motion function I find very beneficial for more critical evaluation of what's going on, and then also providing feedback to the patients and athletes. I hope you found that helpful, and thanks very much for your time.